Hello, welcome to HIV Updates 2018, Evaluating New Therapies for HIV. This is a program jointly provided by the North American Center for Continuing Medical Education and DKB Med, supported also from an educational grant from Gilead Sciences. So I'm Ethel Weld. I'm an assistant professor of medicine at Johns Hopkins, specializing in infectious disease and clinical pharmacology. My co-faculty member, Allison Agwu, also contributed to content. She's an associate professor of pediatric and adult infectious disease at Johns Hopkins. Dr. Zoellner is a PharmD, who's a senior clinical pharmacy specialist in HIV and HCV through the Parkland Health and Hospital System, and a clinical associate professor at UT Southwestern Medical Center Infectious Diseases Division in Dallas, Texas. These are our disclosures. The educational objectives of this session are to explain the importance of early diagnosis of HIV and to compare some of the newly FDA-approved medications to their older counterparts that we've been more accustomed to using over years. Discussing therapies that are not quite yet approved but are in late-phase development and are expected to emerge soon is also a goal of this talk, and to identify medications that have a role in treating HIV per the most recent treatment guidelines for HIV. And we wanted to provide you with some definitions because we know a lot of this can really seem like alphabet soup at times, but these are some slides with definitions of acronyms just for your reference throughout. You can come back to these. So the first section is to discuss HIV epidemiology, testing, and demographics, and this is with a focus on the United States. So this slide presents the subpopulations most affected by HIV in the United States, and you can see this is data from 2016, that the majority of the epidemic is born among MSM in terms of incident HIV, and in the 20 to 29 age group is accounting for a large spike in HIV diagnoses in the United States. People who inject drugs account for about 7% of the epidemic now, and 41% are less than 30 years old. This is the estimate of the total burden of HIV in the United States, a bit over 1 million cases, and it's an epidemic that has been shifting over recent years because of advances in therapy, to the point where 27% of patients who have HIV in the U.S. by the year 2035 will be greater than 65 years old. And with that comes comorbidities, so 44% of them have 3 or more other comorbidities apart from HIV. So here you see demographic breakdown of cases of HIV in the United States. These are the guidelines for HIV testing in the U.S. So the recommendation is for everyone between 15 and 65 years of age that they be screened for HIV. For everyone who is pregnant, whose HIV status is not yet known, they must be screened, and they must be screened with every new pregnancy. And then there is more frequent screening than yearly for those at increased risk of HIV. For example, men who have sex with men, youth, people who have at least semi-habitual habit of injecting drugs, those who have TB or other sexually transmitted infections that can go along with HIV, and those who are taking pre-exposure prophylaxis against HIV. So that screening recommendation is every 3 months for some of those groups, and of course as clinically indicated. The interval is not really explicit in the guidelines, but the CDC did conclude that there's not enough evidence to support greater than annual screening for MSM in 2017. So annual screening for MSM is their current recommendation unless there's some specific risk that occurs. So there is basically a drive towards routine testing that's offered routinely to everyone as part of a system of care, and that's not only based on perceived risk, because that stands to miss proportion of people who are infected. The current testing strategies that are in place lead to the fact that significant numbers of people are identified at later stages of disease. mostly because individuals who do not know that they have HIV account for greater than half of new sexual transmissions of HIV. It's of interest to know how many people do not know their serostatus, and 1 in 7 people with HIV in the U.S. do not know their status. 1 in 2 youth between the ages of 13 and 24 who have HIV do not know their status. And this is important because people's risk behaviors do change once they know they are infected. So earlier testing leads to earlier diagnosis. The earlier you're diagnosed, the earlier you can be linked to care. And this helps not only the individual, but is a step in blocking transmission for the community. Because if that individual's viral load is down, their risk of transmitting to someone else is lower. This led to the idea of undetectable equals untransmittable. So that's the U equals U campaign, which is a broad movement that arose out of advocacy and also directly from the science. The partner study, HPTN-052, showed that among HIV discordant couples, one of whom was infected and the other of whom was uninfected, there was a dramatic reduction in HIV transmission when the HIV-infected partner was treated with antiretrovirals and became virologically suppressed. This was later borne out in other populations in the opposite attract study, which looked at serodifferent couples and men who have sex with men. And there's not been one single phylogenetically linked transmission if the HIV positive partner's viral load was undetected below 200 copies per ml. So this campaign is intended to reduce stigma in the community that's long been associated with this disease. The WHO and DHHS guidelines, therefore, both recommend ART for the prevention of transmission of HIV, and not just for the benefits it gives to the individual who has HIV. So this depicts the cascade of care in the United States. So out of the 1.1 million people living with HIV in this country, about 85% of them are diagnosed, 62% of them are linked to care, 48% retained in care, and 49% virally suppressed. So a lot of challenges in reaching the undiagnosed and linking to care the diagnosed. There's, of course, room for improvement. This figure shows mortality and antiretroviral use over time. So you can see these are slides from the CDC covering the early antiretroviral era, depicting that the number of deaths per 100 person years dramatically fell as the number of patients with uptake of highly active antiretroviral therapy increased. And that's borne out in a slightly different visual display in the upper right-hand corner. Lifespan among those with HIV in the late antiretroviral era is depicted in this blue chart below. So this depicts the life expectancy in Europe and North America between HIV positive and HIV negative individuals. So a man who is HIV positive is expected to live on average 73 years, whereas a man who is HIV negative, 77 years. For women, the HIV positive live an average of 76 years, and the HIV negative live an average of 81 years. So you can see that there is near convergence of lifespan between those who have HIV and do not have HIV. The causes of death among those who have HIV are the majority of the time non-AIDS related. They are malignancy, liver failure, often associated with hepatitis co-infection, infections that are not AIDS related, heart disease, neurocognitive disorders. So overall, the thing that ends your life if you have HIV is no longer HIV, it's a comorbidity. So just to move on to a discussion of current and emerging therapies for HIV, to talk about the moment when you would choose a new regimen and why. So one of the reasons for choosing a new regimen would be for initiation of treatment in a patient who is treatment naive. Another reason would be if you have a patient who's been on therapy for a while but who needs a switch of regimen due to treatment failure. And it's always hard to tease out whether that is because of adherence concerns, they just can't manage to take the regimen, or because of resistance of their virus to the medicines they're being treated with. Side effects and toxicity can certainly necessitate a switch, especially if you have a component of the regimen you're treating them with that is known for that toxicity. If someone has virologic suppression and is doing well, but you have concern that they may intermittently have adherence struggles and be at risk for developing resistance, and you have an emerging availability of a more potent drug that has a higher barrier to resistance, that would be a very reasonable cause for changing a regimen. In addition to developing new comorbidities such as hepatitis B that need their own treatment in a co-treatment manner with HIV. So the factors that would influence your regimen choice for someone who's never been treated for their HIV before are many. You think about pill burden, you think about the size of the pills, the number of pills, the number of times a day someone has to take a pill, the amount of trouble the person you're dealing with might have taking medicine several times a day, drug-drug interactions, and I want to plug this HIV drug interactions checker here that I provided the link for. It's from the University of Liverpool website, and it is incredibly helpful when you're starting a regimen to run it through the interactions checker, not only to understand what the kinetic interactions are between the drugs, but also whether they are clinically meaningful for your patient. Thinking about side effects and long-term toxicities, if you have someone who has vulnerable kidneys already, you might want to stay away from medicines which in a cumulative fashion affect the kidneys. If someone is pregnant, you take into consideration their likelihood of transmission to the fetus and which drugs have been studied in pregnancy. You take into account their baseline CD4 count and viral load, and whether they have certain predispositions that are genetic towards hypersensitivity to components of an HIV regimen. One of those is the HLA-B5701 allele, which if you inherited this gene signature, you're at increased risk of developing hypersensitivity to abacavir, which is one of the main NRTIs in the nucleoside reverse transcriptase inhibitor class to treat HIV. And all guidelines agree that if you are HLA-B5701 positive, you should not get abacavir. The DHHS recommendations for initiating ART are depicted here. Basically, older recommendations split this up by CD4 cell count level. The current recommendation is that all individuals with HIV, regardless of their count, be treated with ART, and it is recommended as a transmission prevention step for others. And embracing and adopting strategies to increase adherence is of critical importance. The language of the recommendations from both the DHHS and the IAS of note will transition to people first language, which means referring to people with HIV or people living with HIV instead of HIV-infected patients. So there are some factors that are going to increase your urgency to start ART. If someone is pregnant or has high pregnancy potential, i.e. is a woman of reproductive age not on an effective contraceptive who is sexually active, you will definitely want to start her on ART sooner rather than later, again, to decrease the possibility of maternal to child transmission. If someone has AIDS-defining conditions, including various opportunistic infections, but also AIDS-associated malignancies or neurocognitive illnesses, then there is urgency to treat with antiretroviral, which can reverse the progress of many of those diseases. Those whose disease has progressed further, who are at a later stage of illness with lower CD4 counts and potentially some end organ damage from HIV, such as HIV-associated nephropathy, there's an urgency to treat them. Any sort of infection that you think might be an acute HIV infection, perhaps the acute antiretroviral syndrome, would be urgent to treat as soon as you've identified it. And then those with hepatitis B or C co-infections, since their morbidity is so high. There is high complexity in the HIV drug market. There's 8 drug classes, new classes really emerging every year, and then greater than 40 products. They're depicted here for your reference. I won't go into every drug mechanism because it's not the focus of this talk, but just to say that there are many choices to make when treating someone with HIV. So these are the Department of Health and Human Services 2017 guidelines on what to start. And the box in yellow indicates what these recommendations consider the first-line regimen. So dolutegravir, abacavir, and 3-TC is a first-line regimen if their HLA-B5701 gene signature is negative. Dolutegravir combined with tenofovir and FTC is considered line, and as is elvitegravir that's cobicistat boosted, and raltegravir. Now, one thing about these guidelines is that they are somewhat agnostic as to which is better between TDF and TAF, and that's something they don't have in common with the IAS guidelines, which puts TAF-FTC-based combinations more prominently first line. The boxes below are advisories and warnings that emerged after these guidelines came out, so just to keep you abreast of how they have evolved and changed since they were released. The second box basically is just adding the fixed-dose combination product of bictegravir, tenofovir, alafenamide, and emtricitabine as one of the first-line recommended initial regimens for people with HIV, so it belongs in the yellow box, and it will be in the next version. And then there's something that came out May 18th of this year, which has generated a lot of discussion and a lot of buzz, basically about a potential safety signal of an increased rate of neural tube defects in infants born to women participating in a trial of dolutegravir and other antiretrovirals in Botswana. So those are being investigated, those findings are being rigorously analyzed, and what to make of those findings is to a certain extent up in the air. But there's been interim guidance released basically stating that women of childbearing age who are trying to become pregnant or wishing to become pregnant should discuss alternative regimens to dolutegravir, and pregnant women who are already on dolutegravir should not stop it and should just discuss with their provider next best steps. It's of note that it's not understood yet whether this is a clear signal that's been reproducible, and it's not understood whether this would be a class effect across the integrase strand transfer inhibitors or something peculiar to dolutegravir if it is indeed a signal. The next slide just goes into recommended initial regimens in certain clinical situations. So, for example, if your baseline viral load is less than 100,000 copies and your baseline CD4 before treatment was greater than 200 cells per cubic centimeter, then you would be appropriate for a rilpivirine-based regimen, and you would be appropriate for raltegravir-based regimen with abacavir 3-TC, for example. But taking into account if someone has a higher viral load, higher than 100,000 copies, that's someone who should not be getting a rilpivirine-based regimen out of concerns for virologic failure that emerged out of the trials. So the regimen choice based on pre-ART characteristics is depicted in this slide. And just to further highlight, if you have someone who's come to you with acute HIV, I've already told you that there is urgency to start antiretrovirals in that situation, both because you reduce the transmission of the virus, which is easy to transmit in the acute setting because it's many logs higher in terms of viral load than at other stages of the disease, and because it benefits that individual because of affecting the establishment of the latent reservoir and other factors. That means a rapid initiation means you initiate antiretrovirals the moment you see a person without waiting for genotypic information and lots of testing to come back. And the recommended ART regimen in that situation, both in acute HIV and in rapid initiation, not otherwise specified, where you just basically initiate the second you find out that they are positive, is a regimen with a very high barrier to resistance that would be an appropriate treatment even if they had a slightly resistant virus. So that would be a PI-based regimen with darunavir that is boosted, or a dolutegravir-based regimen. These are the IAS guidelines, again, just to emphasize that they do not consider TDF first line anymore and have incorporated TAF, but otherwise are really fairly similar to the DHHS guidelines. New and emerging therapies are worth discussing, both to compare the benefits and risks of the therapies and to assess them against older therapies that people might be more accustomed to. So just to read a polling question before we start, which of the following is the primary difference between tenofovir disoproxil fumarate, which is abbreviated TDF, and tenofovir alafenamide, which is abbreviated TAF? Is TDF associated with lower renal and bone toxicity than TAF? Is TAF associated with lower renal toxicity but higher bone toxicity than TDF? Is TAF associated with lower renal and bone toxicity than TDF? And then the last option is TAF but not TDF is licensed for PrEP. So I'll give you a moment to think about that and decide on a choice. Here's a timeline of the FDA-approved HIV drugs over the past really almost 30 years now. The initiation of zidovudine was in '87, and we're taking this right up to 2018. So you can see that there's an increasing number of agents on the market every year. I just wanted to focus on the last 4 years to show you what has come on the market recently and put a spotlight on the new ART. And I do realize this is a lot of letters. I've provided the abbreviation explanation at the bottom of the slide. But the ones that have come out in just this year are the fixed-dose combination of Biktarvy, and they also include a new class of HIV medicine, a monoclonal antibody, the first ever approved for HIV treatment, called ibalizumab. So I wanted to emphasize that something that Adherence is the smallest possible pill size that still gets the patient the regimen that is going to suppress their virus. And this is a comparative slide showing the relative sizes of all of the fixed-dose combinations and single regimen tablets for HIV. Most of these are really huge pills. The ruler at the top is 2 centimeters, so these are very large pills. Of the single drug tablet, TasP, and which is a dual drug tablet, but it's not the complete 3-drug fixed-dose combination. Rilpivirine and dolutegravir are among the smallest. But taking that into account benefits patients because if they have pill aversion and can't swallow, then they can't get their virus effectively treated. So this is the mechanism of TAF, and the thing to take away from this is that plasma levels of tenofovir, both TAF and TDF are prodrugs of tenofovir, which goes into cells and is converted into the active form, the active metabolite, tenofovir diphosphate, which chain terminates HIV. And plasma levels of tenofovir with TAF are much lower, 10-fold lower than plasma levels of tenofovir with TDF. However, intracellular levels of the active metabolite with TAF are 4-fold higher than they are with TDF. TDF is associated with lower lipid levels. There's an unclear mechanism there, and it's of unclear clinical significance, but it's likely attributed to lower levels of tenofovir seen with TAF than with TDF. TAF is not labeled to be used in people with a creatinine clearance less than 30, and there's very limited data on its use in pregnancy. I did want to mention that cobicistat was a relatively new pharmacologic booster that came on the market that inhibits only CYP3A4, but there's some concern that when compared to ritonavir, cobicistat may have more drug-drug interactions and may boost other drugs in a different manner than ritonavir. They should not be considered exactly parallel. There is a new once-daily formulation of raltegravir that's been approved based on the Once Merck trial. There's a formulation fix that went into this preparation of a 1,200 milligram daily dosing strategy for raltegravir that was compared in this trial against BID twice-a-day dosing of 400 milligrams and was able to demonstrate non-inferiority of viral suppression, et cetera, studied in combination with TDF, FTC. So the week 96 rates of viral suppression less than 40 copies were 81.5% in the daily group and 80% in the twice daily group, with a non-significant difference between them. So once daily pills have been shown to adherence over twice daily and 3 times daily pills, and so that should be taken into account. Biktarvy, that I mentioned before, the new kid on the block for recommended regimens for first line against HIV, is highly potent. It has a trough level that's 20-fold above levels needed to kill 95% of HIV. and it's useful because it can be given once daily. It doesn't need to be boosted, and the boosters do increase drug-drug interactions with other elements of a regimen. And it is non-inferior compared to dolutegravir when studied in combination with TasP in a randomized placebo-controlled trial. It's active against variants that can have resistance against the other members of the integrase strand transfer inhibitor class, and it's got a long dissociation constant from the HIV virus. It kind of gloms onto the virus for a long time and creates a high barrier to resistance. It is metabolized, so there are concerns about drug-drug interactions with, for example, rifampin decreasing the bictegravir area under the curve, exposure, because it induces its metabolism. That sort of thing has to be taken into account, and again, I would strongly urge you to plug new regimens into the drug interactions checker. Ibolizumab, just to focus on this, is a monoclonal antibody that blocks HIV entry by directly to the CD4 receptor on the host cell that enables HIV to enter and doesn't allow it to make the conformational changes that are required for cell entry. It has received orphan drug approval for treatment of people with multi-drug resistant HIV who are out of many other options, and it's active against both a virus that uses the CCR5 receptor and a virus that uses both the CCR5 receptor and CXCR4 receptor, which makes it of higher applicability than Maraviroc, which is only active against the CCR5 virus. It's got a long half-life, so this is injected by IV infusion every 2 weeks. So again, strategies getting away from daily dosing strategies are being embraced. And again, did lower viral load significantly in highly treatment-experienced patients after 7 days of just virtual monotherapy with this. The first lone duotherapy fixed-dose combination is dolutegravir and rilpivirine, intended to be given to suppressed patients for further suppression of their HIV. Every time you take an element out of a regimen, you have less drug-drug interactions and you lower the cost. So moving towards duotherapy, if they're rigorously studied, it does make sense from both a systems approach and for the individual patients. So this was studied in the phase 3 SWORD-1 and SWORD-2 switch study, where people switched to a regimen of dolutegravir and rilpivirine from a 3 or 4 drug regimen, maintained their suppression greater than 95%, and none had any baseline resistance, so that's important to keep in mind, and these were all patients who were already suppressed. But this is a nucleoside reverse transcriptase inhibitor sparing regimen, doesn't affect lipids, and it's going to be less costly. One thing to remember about rilpivirine is it has to be taken with a meal. It requires acid for absorption, so it cannot be taken in conjunction with proton pump inhibitors. You can give it with ranitidine and H2 blockers, but you have to space it in time considerably away from them. I wanted to transition to talking about some anticipated new agents from classes that we've discussed before, but new formulations and new molecules. So doravirine is an NNRTI. The NDA, the new drug application, was submitted by Merck in January 2018, and it's expected to come on the market in the fall. And it's a once-daily medicine that really retains strong activity against the most prevalent mutations against agents in the class. And it's been found to have really strong safety and efficacy findings in 3 trials with CAR-related names, Drive Forward, Drive Ahead, and Drive Shift. But non-inferior efficacy and improved safety is of note. Cabotegravir is basically an injectable form and an oral form, a drug very similar in structure to dolutegravir, but the cabotegravir long-acting is a nanoformulated form that can be given via injection either every 4 weeks or every 8 weeks and maintains viral suppression, as was shown in the LATE-2 trial. Cabotegravir co-formulated with rilpivirine is going to be a long-acting co-formulation, the IM version of Juluca, for potentially people who did well on oral Juluca and want to transition to a less frequent dosing medicine. And again, cabotegravir long-acting will emerge on the market within the next year likely, and is under study not only for treatment but for pre-exposure prophylaxis. It is available in a limited expanded access compassionate use program for those who really prove unable to take daily oral pills. and the link is shown there. And again, more duo therapy on the horizon, going with a theme of eliminating elements from a regimen where 2 drugs will do okay. I'm kind of getting away from that initial idea that a cocktail was mandatory. You still can't really have monotherapy, but there's been really promising results from duo therapy with the cost saving that I mentioned. So the combination of a fixed dose, a combination of dolutegravir and 3-TC was studied in people who switched to drug maintenance from a suppressive regimen, and 97% of them remained virally suppressed at 48 weeks. So no concerns with resurgence of virus or resurgence of resistant virus because you only had 2 elements in the regimen. So this showed good efficacy in treatment-naive patients as well who had a viral load less than 500,000. Really does remain to be seen whether this is a good option for someone with a much higher viral load. So of interest in the pipeline are a few agents I list here just simply because of their new classes that demonstrate the amount of activity in the drug development space that has taken place in the last 5 to 10 years. So Pro-140 is an IgG4 antibody that binds to the HIV co-receptor that it uses for entry into the cell, and it is active against virus even that's resistant against Raviroc, which is another entry inhibitor. This would be a once weekly subcutaneous injection, so looking for a partner that can also be given weekly would be the issue for just streamlining of the HIV treatment. Fostemsavir is an oral prodrug of an attachment inhibitor, again, preventing HIV attachment to the host cells by binding to a protein on the host cell membrane called GP120. And again, even in people with more than 3 drug class resistance, there was 90% viral load undetectable at 96 weeks in both groups studied. So it was studied against atazanavir, ritonavir. Both had good suppression. Albuterol is a peptide-based fusion inhibitor meant to be given IV every 1 to 2 weeks, potentially a sub-Q eventually, but again, another option for those with virologic failure. So lots is emerging to treat the issue of intractable resistance. So the key takeaways from this talk are really that HIV is prevalent in the U.S. and new HIV infections continue to occur and the issue continues to expand, and these incidences of new HIV are even rising in some groups rather than declining. Young men who have sex with men of color are disproportionately affected, and it's important to do routine screening of people in your clinic to be able to detect those who do not know that they are infected. Guidelines do recommend that ART be started on all HIV-positive individuals. There's no longer any cutoffs for CD4, and they emphasize treatment regimens that include an integrase strand transfer inhibitor and really focus on lowering pill burden, maximizing tolerability, and still not sacrificing efficacy. Products that were approved over the last 2 years include new versions of familiar agents, so same classes, new versions, improving pill burden by lowering dosing frequency, a new duo therapy, and again, a monoclonal fusion inhibitor. Things that we expect to be improved in the next 12 to 18 months include really at long last injectable long-acting antiretrovirals for those who it's going to work better for them to get injections every 4 to 8 weeks than taking daily pills, and the new NNRTI, doravirine, which has an extremely high resistance barrier. So at this point, I'm going to turn the program over to Dr. Zoellner. Take it away. Thank you.
Thank you, Dr. Weld, for that introduction. Today I'd like to be talking about the role of specialty pharmacy in HIV care. Our polling question is under the current Department of Health and Human Services guidelines. Which of the following are true? A, all recommended initial regimens have low pill number. B, the majority of recommended initial regimens are single tablet regimens with 1 integrase strand transfer inhibitor and 2 nucleoside reverse transcriptase inhibitors. C, 3 of the recommended initial regimens are those listed, or D, all of the above. While many pharmacists are used to working with patients who have private insurance through their employer or their spouse's employer, that's actually a minority of HIV patients. And when we look globally at the almost 37 million people who are infected with HIV, a significant number of them don't have access to medical care or to medications. Unfortunately, as Dr. Weld has already presented, here in the United States, where 100% of our patients have access to HIV medications, only 49% of them actually take them every day to achieve an undetectable HIV viral load. More sad news is that almost 2 million people became infected with HIV in a single year. So we can see that there's a huge opportunity for specialty pharmacists to work with our HIV patients to actually make us a world leader in not only having access to HIV medications, but taking them every day. Specifically here in the United States, 50% of all people living with HIV actually only live in a very small number of states, 5 states to be exact. Pharmacists working in these 5 states are really counted on by both providers and patients to ensure safe and effective HIV medication use. Many of you may have been surprised to listen to some of the things in the previous lecture talking about how HIV is now a chronic medical condition, almost like diabetes, that you can just take medicines one time a day and you can do great and live a long life. And some of you may ask, well, how did that happen? So I'd like to point out some landmarks on our journey from a death sentence to a chronic medical disease. In 1987, we had our first HIV medication that was FDA approved with a very high price tag, $10,000 per year. Unfortunately, that price tag has remained with HIV medicines even into 2018. While the life expectancy with those original medications was fairly low, we've seen that life expectancy in the early 90s has increased to now, in 2009, the life expectancy is really no different for an HIV patient who's diagnosed prior to a decline in their CD4 count than somebody who doesn't have HIV at all. But this success comes at a high price. About 74% of HIV care is actually specifically related to the cost of HIV medications. Because of this, the federal government funds a significant amount of HIV medications in order to have our patients, both here in the United States and worldwide, have access to this life-saving treatment. We are in a new era in 2018 of HIV care where our focus is really managing HIV as a chronic medical condition in primary care settings. This is different than what we were doing with having the majority of our patients followed in infectious disease specialty clinics. What this means is internists, family practitioners, and mid-level providers are the primary prescribers of HIV medications. They heavily rely on pharmacists to review our patients for drug interactions and educate the patients on the correct way to take the medications. The movement in the pharmaceutical industry towards reducing pill burden has helped significantly improve adherence. It also has reduced the number of side effects and toxicities that our HIV medications have, since there is the potential that an HIV patient would be diagnosed at the age of 20 and live to be 80 with HIV, providing them 60 years of exposure to some of these medications. When we look at the Department of Health and Human Services guidelines, I find that they are very difficult for new learners. And so for my students and my residents, what I do is I go through the guidelines and actually write out in words the Egyptian hieroglyphics of all the abbreviations that are used. So what you'll see on the next 4 slides are the actual generic and brand names of the currently recommended medications. And this may look more familiar to you as pharmacists who are used to dispensing HIV medicines. Since this was covered so well in the previous lecture, these 4 slides are just here for your review. What I would like to have you note in the purple is that all of these medication regimens have very low pill numbers. The cost, though, has not changed. From 1987 to 2018, HIV medications remain a top 10 specialty drug. For both our state Medicaid programs as well as the Affordable Care Act health exchange programs, which are federally and state funded, the majority of specialty medications are actually HIV medicines. And this trend is only expected to continue. For those of you who have filled prescriptions, some of you may have been shocked at the cost of a medication being $1,500 to even $4,000 a month for our patients. Generic medications previously really have not significantly impacted the cost of HIV care. By the time an HIV medication actually was released from patent, it had usually been replaced in clinical practice by newer, safer, and more efficacious HIV medicines. However, 2018 promises an opportunity to change that. The original version of tenofovir, which is called tenofovir disoproxil fumarate, or TDF, will be released from patent this year. That has the potential to change the marketplace as other pharmaceutical companies pick up tenofovir and other already generically available nucleosides to create their own single tablet regimens that could be lower priced than current available single tablet regimens. The other opportunity with this generic availability of tenofovir has to do with pre-exposure prophylaxis. HIV-negative patients are able to take tenofovir plus emtricitabine in the combination product Truvada as part of an overall risk reduction strategy to try to prevent HIV transmission. This is regulated through the FDA through a Risk Evaluation and Mitigation Strategy, or REMS program, that without specialty pharmacists, few providers would actually be able to meet and check all the boxes that are necessary to prescribe and monitor our patients. So possibly the generic availability of the original version of tenofovir could expand our HIV prevention efforts. Specialty pharmacies have a huge role in adherence, and I know many of you are asking me, Dr. Zoellner, what on earth do you need my help for with a patient taking one pill once a day? And I tell you truthfully, I need all the help that I can get. We have seen countless studies, many listed at the bottom of this slide, that show that our patients who work with our specialty pharmacists have better outcomes with improved CD4 counts and reduction in their viral load, which not only benefits them, but also reduces the risk of transmission. Our specialty pharmacies not only work directly with our patients, providing clinical interventions, but also can do psychosocial assessments. Many of you have integrated nursing staff that work with you, as well as working with a lot of financial programs. For patients who have private insurance, it's important for our specialty pharmacies to be well-versed in the pharmaceutical company copay assistance programs to help our patients remove any financial barrier to receiving their medicines. Some of you also work with our state AIDS drugs assistance programs. In the state of Texas, our specialty pharmacies do a lot of the dispensing for the ADAP program, and some of you even work with our patients who have no insurance through a pharmaceutical company patient assistance program. I can't emphasize enough how important the review of drug interactions and counseling our patients on correct and safe use of HIV medications really is. I think the future of HIV therapy is incredibly bright. To be able to have a medication that would be able to have our patients live long and healthy lives seemed like a dream years ago. But the current cost trends for HIV medications are just not sustainable for a disease that is a global public health concern. While a significant portion of HIV medical care is subsidized through the federal government, both here in the United States and worldwide, there is the opportunity that generic medications could make the U.S. cost of HIV care more affordable. What's important to keep in mind about generics, though, is that single tablet complete HIV regimens taken once a day are the standard of care. So having patients go from taking these single tablet regimens to something that would be 4 and 5 pills a day just because one medicine in the combination product is generic is not ideal. Specialty pharmacists can help both our HIV-negative patients prevent themselves from becoming HIV infected through risk reduction counseling and the provision of pre-exposure prophylaxis, which is Truvada. But more importantly, you can help our HIV-positive patients by making sure they're going to their medical visits. They have refills of their prescriptions. They're taking their medicines every day, and they're achieving that undetectable HIV viral load. It is crucial that we do these steps in order to reduce the number of new HIV infections and decrease the overall disease burden of care. In the 19 years that I've worked with HIV patients, I am constantly amazed at the phenomenal changes that have happened and the fact that this truly is a chronic medical condition. But what has happened is that a lot of my patients are doing so well that I only see them once or twice a year. And that's opened potential gaps in HIV medication adherence that I think there's a tremendous opportunity for specialty pharmacists to step into and take an active role, to interact with our HIV patients as they come to fill their prescriptions on a monthly basis, to educate our patients about why it's important to be adherent to their HIV medications every day for the rest of their life, identifying any issues with non-adherence and reporting that back to the prescriber so that we can be aware of that and address it prior to their next visit, removing any financial barriers to adherence by helping our patients navigate the very difficult system for paying for medicines, reviewing drug interactions for safety, and also working with our HIV-negative patients and providers to help us meet the REMS criteria for pre-exposure prophylaxis to reduce new HIV infections. And with that, I'll take any questions that you may have.